old individual. So there are a few things that are identified with her. So the underlying major issue with her is her spastic quadriplegic cerebral palsy. And the next one will be she has this infantile epilepsy syndrome. And at the moment, currently, her issue is the admission for the ward is right hip dislocation, which is symptomatically admitted.
Okay.
And then another issue is early puberty with her. So these are the issues that are identified with her. So the first. So I get a bit
No social issue.
So psychosocial impact on the family also.
Okay.
So just to give her background a bit. So she was delivered normal at 38 weeks. She's still child, so nothing happened. No issues antenatally or perinatally. She was discharged well at birth. Then around 5 months old, she developed a febrile seizure post-vaccination, about 12 hours post-vaccination. It was a routine vaccination. Then at the time she developed a seizure at a very low grade temperature. It lasted around 20 minutes, requiring some loading of anti-epileptic everything. Then she was discharged well. Then she had another seizure, a breakthrough seizure again around 7 months old. Also with a low grade fever, she developed seizure again. So at the time, she was eventually started on anti-epileptic, a single one, and said Cerebral. Then at 1 year, 5 months old, she developed again a febrile seizure, again like a sort of a post-vaccination fever episode. Then she had a febrile seizure. This time it was a status epilepticus, lasting about 45 minutes to 1 hour at the time. She reported to hospital Aras Damansara. They had difficulty with aborting the seizure, so up to 1 hour unable the seizure was persistent. Eventually she was intubated and required a long ICU admission at the time. Then after this episode, child had some deterioration in terms of her development. Eventually she was told to she was diagnosed with CP.
So is it CP or neuroregressive disorders?
CP post event.
Okay. So what type of CP?
So hers is a spastic quadriplegic cerebral palsy.
Okay. And then JMFCS?
She's GMFCS 5.
Okay. Alright. So what do you think about the CPs? Okay.
So the CP. So she has a few issues regarding this CP. So one will be the current admission hip dislocation. She was monitored for it, but then they noted some apparently at the auto rehabilitation clinic they noted worsening of the her hip joint eventually dislocated. So decided for a procedure correcting procedure for it. And then besides that, so for the seizures initially she had difficulty controlling the seizures as well, the initial period of her life, and then subsequently with the adjustment of the anti-epileptic, able to control now. So previous seizure, almost every day she would have seizures, about 10 episodes. More to parents, the way they describe it is more like a jerking sort of seizure. She would be unconscious, but it lasts very briefly, much 1-2 minutes, but she has up to 10 episodes. So anti-epileptics, it was single anti-epileptics was just increasing and reducing the dosage, eventually they control up to 2 episodes per day. So latest, they say up to 2 years she has been seizure free already, almost 2 years already. But she has some, I would describe it as the dystonia sort of thing. In the morning when she wakes up, she has some movements, but it aborts spontaneously.
So the seizures is mixed type also lah. Spastic with some dystonia.
Different, spastic, with this.
So probably it's a mixed type. Does he has anti-dystonia medication?
What? I think she has baclofen and palsy
Okay lah. So probably it's a kind of mixed type spastic with dystonia. Spastic dystonic kind of CPs. Right? Do you know how many types of CPs are there in term of motor type?
There's dystonic one.
Okay.
This kinetic one also.
Spastic, the one is under one term, basically dyskinetic, which is include your dystonic, include your chorea-adaptoid. Okay. So dyskinetic is the big term lah. Okay. Alright. Then another 3.
There's diplegic.
That one is distribution. So there's spastic, there's kinetic, there's ataxic, and then the mixed type. Ataxic basically involve your Cerebellum. Your dyskinetic involve which part of the brain? Basal ganglia. Anything that movement is always basal ganglia involvement lah. Okay, that's why patient with kernicterus is a dystonic type most of them, because your bilirubin all end up deposited into your basal ganglia. Okay, understand, right? Okay, so your other type on how you distribute the thing, how you classify the distribution.
So that's the
diplegic. This one is
a
quadriplegic. Okay, so they be also hemiplegic as well lah. Okay, that one is based on distribution. And lastly, you classify them based on your functional lah, which is your EMFCS. So first one is always motor type, then second one is your distribution, and lastly is motor functional type lah, EMFCS 5, which is basically backbound lah. Okay, alright. Continue. What other problem that she has in terms of her CPs?
CPs, and then along with the dislocation, of course, she has bilateral lower limb contractures, which she is under rehabilitation team for, and started on baclofen, all these things. And she's also under a physiotherapist is seeing her every 2 weeks, twice every week at home. They hired a physiotherapist to help with the limb exercise. She also has a standing frame at home lah. So every day, macam 45 minutes, she'll be standing on the frame.
So does she need any further intervention on his contractures?
At this moment, because she's just completing a procedure, I think with the limb exercises, it will suffice. But
so what do you think the procedure that she might benefit from in terms of the contracture?
Currently, now is the that's dislocation.
Dislocation, tendon release. Yeah. Before we go for tendon release operation, what else you can give injection? What not?
Botox injection.
Yes, Botox injection. Okay, alright. Some more in terms of CPs punya main problems.
She also has another issue is the swallowing incoordination.
Okay.
It has been addressed. So they've noted around since 2 years. So she has difficulty lah, even with oral feeding. They tried soft diet, difficulty also. Eventually, a gastrostomy tube was inserted for her. And then currently, after that, changed to Mickey button. So far, they've been giving pactive feeding about 100 to 120 meals per month.
How's the growth chart?
Growth is so the height. Didn't mention yet. The height. The weight is around 70 centimeters. So she's increased quite a bit also.
Okay. So what you want to do about it?
So the way dietitian team will have to be on board. So I will have to adjust her feeding.
Alright. You want them to be so heavy like that? No. Why?
One, it will be difficult to
take care
of the patient. The other one, the sauce and everything will be worse also.
Alright. Okay. Some more on the CP, what else? Apa lagi? You already mentioned seizures, you already mentioned the feeding issues, you already mentioned the contractures, the hip as well. What else?
Constipation is another thing. So initially that was also addressed already at this moment. So previously it was difficult for her. She would take up to 3 to 4 days. So she was already started on lactulose already. So initially 3 times a day, now into 2 times a day already. So she's able to pass motion daily.
On medication?
She's on lactulose.
Lactulose only lah. Okay.
At the moment, lactulose.
Alright. Why you think it's very important to maintain to ensure this patient don't have constipation?
So constipation,
based on you punya CP type just now, in terms of motor type, what can you relate in terms of this type of CP and constipation?
Quadriplegic, motor type, dystonic.
What dystonia have to do with the constipation? Because when patient have constipation, especially in this dystonia type of CPs, patient can go into overdrive because you don't relieve them the constipation. The patient will have a lot of sympathetic stimulation. Dystonia will get worse. Okay, since you mentioned patient have some form of dystonia as well, I wouldn't allow constipation to happen lah. So really, sometimes you have to treat it a bit aggressive lah. If lactulose not enough, what are the medication that you can consider?
You can give Forlex,
Yeah.
stimulant,
Okay. Alright. Okay, sama. What else about CP?
So for her sleep, so now her sleep cycle for the parents, for them, they are comfortable with her sleep cycle. She sleeps about 8 to 9 p.m. every night. She wakes up at 6:30 a.m. And then during the afternoon, she will take a nap, a short nap, less than an hour. But she's been started on melatonin.
Okay.
Quite.
Still on regular melatonin?
Every day she takes melatonin. Yeah.
Okay. Alright, sama.
And then
in terms of psychosocial issue helping patient with seizures?
So seizure. So psychosocial, both parents are working. Parents are both working parents. So the father is a manager, mother is an IT lab manager as well. So during the daytime, there will be a babysitter taking care of the kid. They also have a younger child, 11 months old. So both of them, the same caretaker takes care of both kids too.
So they send the patient to caretaker or caretaker comes to them?
Comes to the house.
Alright.
And after that, when parents are back at home, they will be taking over the caretaking.
So in terms of coping, parents are kind of coping, no like mental health issue, whatnot?
During the initial period, they say there was a difficulty of accepting because the child was growing up okay, and then there was a regression something. So after that, with family support, they say they have good family support as well from both the grandparents of mom and the father's side, maternal and paternal. So they are currently caretaking. They are really comfortable. They've established a good care.
Okay. So what about vision and hearing? Any issue?
Also, there is an issue with her vision as well. So after the event, after the hypoxic event that happened due to her seizure, she's unable to see. So the parents were told her there was an effect of her cranial nerve.
Alright.
So it's a cranial nerve palsy. She's unable to see. And she's under ophthalmology clinic follow-up every year.
Hearing?
Hearing?
Not sure. Okay. Alright. What about the infection? Any recurrent infection?
So before the pack tip, she had some issues with microaspiration. There's been admissions for aspiration pneumonia. So far, handling it latest. Recently this year required one admission. It was a viral infection, upper respiratory tract infection. So that one also, along with the swallowing, drooling is not a very big major issue with them, but she does have some drooling, which parents they just clean it up. It doesn't really affect her breathing or anything like that.
Okay.
But the physiotherapist that comes to the house does do suction once a week.
Alright.
They don't have a machine at home.
I see. But if patient have issue with drooling, so you can consider?
So we can actually start them on maybe atropine or
some more?
glycopyrrolate,
Some more? Scopolamine patch. Okay. Alright. Okay, lastly, I think in terms of dia punya development now,
she's just her developmental age is around 3 to
4 months lah. Okay.
So she's able to partially control.
Alright. So lastly, anyone have talked about palliative care in term? It is early palliative punya support and all that.
So far, never.
Never lah. Okay. So if this kind of patient never had that kind of introduction to early palliative, so what you want to do?
Probably like to introduce them to the mostly for counselling and support.
Okay, you can introduce lah, but I think it's probably part of your job also lah to tell them the expectation, the life expectancy, which is what?
Life expectancy for quadriplegic CPs, actually they can live with good care, they can go up to 50, 60
Yes,
years
can.
But,
So, but you must insist to them lah. Every time they have a major infection, their life expectancy will be much reduced afterwards. Okay, the more infection they get, the shorter their life expectancy lah. Okay, so they must understand that kind of thing also lah. So the moment the infection getting more and more and more, that's probably the time to bring in the palliative lah. I think in terms of general pediatrics point of view, you probably have to counsel that point lah. I think 4 years they probably will be okay for many years, but at a certain point when they goes in their 20s, 30s, if they are more prone to get infection, as you know, as you said, patient have micro aspiration and all that. So it predisposes patient to recurrent lung infection. So when you have recurrent lung infection, what happened to the lung after a while? You want to label that as what? Lung, so many infection, and examination you see clubbing. Chronic suppurative lung disease lah. Okay, could be chronic lung, but most of the time it's chronic suppurative lung disease lah. Okay, so you basically want to monitor for that as well lah. Okay, so you have 5 more minutes. So I want to focus on your another issues. Basically, you said this patient had some early puberty issue. So how you want to differentiate? Is it premature telechy? Is it central precocious puberty?
So there is premature telechy for her. As you can see, the hormonal workup, everything done was fairly normal.
Okay,
so
alright.
It's not progressing.
Okay.
Since 2 years, noted some like telechy, and then after that it's been static.
Okay, how does that tell you it's not CPP?
CPP.
What's the features of CPP? Central precocious puberty? You must know lah, because you want to differentiate this one premature. You already mentioned there is no hormonal workup, everything normal. Okay, what else? What else? Features of premature telechy that differentiate to CPP. Is there any secondary characteristic happening? Secondary sex characteristic, for example? Is there any like any?
There is development.
Okay, it's just some breast development, right? Is there any hair anywhere?
There is pubic hair also.
Pubic hair.
Around stage 2.
Okay. Alright, that's pubic. Does it increasing some more?
No.
Okay. Alright. So it doesn't fulfill the CPP criteria lah. Okay, per se. So this patient, for example, okay lah, premature telechy, then you see some growth and all that. So what you want to do if this one label as CPP already?
So of course we will get the endocrine team involved,
Yeah.
and then endocrine team will probably need to come to the patient whether you want to stop. You want to prevent the puberty from progressing further or stopping it, or how the parents.
How you want to stop the CPP?
How do you
What treatment usually endocrine will give? Some GnRH punya injection lah. Okay. So it's basically want to suppress the sex hormone lah, basically. So what is the problem? If patient with CPP, what can happen to the child? Especially kalau normal child with central precocious puberty.
So their growth will probably be some short stature.
They will tall initially, but their growth will be very fastened and shortened. So their final height will be much lower than expected lah. So they can be shorter than their peers. Alright. So the main thing about premature telechy, most of the time it's just isolated breast development lah. But if you involve some pubic hair already, I think that's why they label him as early puberty lah. But it is some form of central precocious puberty lah. When you said there is some pubic hair involvement lah. Kalau betul-betul premature telechy, it's just the breast development lah. Okay. Most of the time, if you do the bone age, you do the bone age x-rays, the hand x-rays, there will be some changes lah. So CPP will cause early closure lah, or advancement of your bone age. Okay. But in premature telechy, your bone age will be expected of. It remains the same as your chronological age lah. In CPP, your bone age will be advanced to standard deviation lah, paling kurang. Okay. So but if you set your hormonal level, your LH level will be normal lah for premature telechy, but in your CPP will be more lah, will be higher than normal lah. Okay, if you do your GnRH stimulation test also, the LH will not respond lah. Okay. But if patient CPP, it will respond. Okay. So yeah, sometimes they do also ultrasound. You can see the follicle ovaries will be bigger in CPPs, but in your premature telechy, it will be simple normal ovaries lah. Okay. So most of the time it's a growth spurt lah. Growth spurt very obvious lah. Okay. Then secondary sexual characteristic, yeah, you can see the pubic hair, ciliary hair, everything lah. Depends on the problem. Okay. So yeah, think something like that lah. Okay, don't forget lah, if this is a girl also, they might have also some vaginal discharge, maybe some menstruation also. Okay. Alright. Okay. So in the end, long case is always student or examiner's led punya process. Even though you can listed every single thing 1 to 7, then sometimes they focus on certain things lah. Whether you can connect the dots or not lah. Sometimes every problems like your CP, this patient with CP, seizures, and even the premature also related. It can be related. Why do you think patient with CP can have central precocious puberty? Yeah, the part of the brain is not normal. So anything you messed up with the brain because of some issues, some tumors, some HIE issues, I don't know lah what, anything lah, operation ke apa ke, it might trigger something lah. Okay, so it's not unusual lah to have this kind of problem, is this kind of patient with some brain development issue lah. Okay, so whether you can click the dot or not lah. So the one yang with thought process already a bit matured, I think you can easily go through every single part of the problem. You still miss, there is some gaps in your assessment. You probably miss the vision, hearing and all that. There are certain things that I probably need to probe further to get that part of history lah. So ultimately, when you do assessment on the long case, assess, not just listing the problem, not just informing the problem. I want you to analyze the problem. Why do you think it happens? I don't think, I want you to see this one is probably purely cerebral palsy, not neurodegenerative disorders lah. Evidence by patient normal, then suddenly head event, then patient stop growing lah. In neurodegenerative, there's features is there's no specific triggers, there is some developmental regression that happens. Okay, and then of course then I would want to assess this disease, then I want to manage this disease, I expected this disease. Just basically some without probing, this one is very good candidate lah. I wouldn't say, even if examiner prompt, I wouldn't say it's not good candidate lah. Sometimes we may prompt also lah, want to basically get the answer out of you. You might probably have assessed it, but sometimes due to exam stress and all that, sometimes the brain also doesn't work. Okay, so just practice lah. In the end, the management, ultimately I want to manage this patient based on by multidisciplinary approach. Always goes for it lah. Okay, so I have mentioned lah, multidisciplinary approach involving what thing? General pediatrician, your pediatric neurology, your rehab specialist, OT, physio, dietitian, hearing, almost everyone lah. So CP is very good case for long case lah. So you must, for your level, you must know CP inside out. Okay, every single thing about CP you must know. So your understanding about motor types and distribution also haywire already. Okay, then must know about GMFCS and all that. Okay, alright, okay lah. Lepas nanti form tu nanti letak dekat. Alright, okay.